And in many patients, this is undoubtedly multifactorial. So, firstly, systemic disease, so multi-organ failure can obviously cause hypoxic and metabolic encephalopathies. The coagulopathy that COVID-19 is well known for may contribute to stroke. Inflammation such as the cytokine storm can contribute to inflammatory encephalopathy and encephalitis. Then COVID-19 can also be, affect the nervous system by direct invasion of the virus, both in the central nervous system, peripheral nervous system, and muscle, causing cell death and dysfunction, and resulting in syndromes such as viral encephalitis and meningitis, and also importantly endotheliolitis. With the peripheral nervous system and muscle system, it can result potentially in neuropathy and muscle injury. We don't know if anosmia and decreased taste is a central nervous system phenomena, peripheral nervous system phenomena, or just a local epithelial phenomena, but that still needs to be elucidated. And then there can also be post or para-infectious syndrome caused due to immune-mediated pathogenic mechanisms, such as GBS and its variants, acute demyelinating encephalomyelitis, and acute necrotizing encephalitis. So I just want to point out one recent publication from even University College London, which described their experience with neurological cases. They described the clinical features, laboratory findings, and treatment and clinical outcome. And I think there's a few important take-home messages from this study. So, firstly, one of the main things that they saw was encephalopathy, and these patients presented mostly with delirium and psychosis. Of note is that the CSF in these patients were normal, and the MRI, when performed, showed non-specific changes, and the majority of patients showed complete recovery with supportive management. The second group of common cases that I saw was inflammatory para- or post-infectious syndromes, where patients typically presented with reduced consciousness and focal or upper motor neuron sign. The majority of patients had abnormal CSF and or abnormal MRIs, and they were treated mostly with corticosteroids, but also with IVIG, but the majority of patients had a partial recovery only. And just to note that 9 of the 12 patients had ADEM, and more than half of these had hemorrhagic changes on the MRI. Then the strokes that they described, as mentioned, we often see it in a large vessel and ischemic stroke. Patients often have very high D-dimers, and often patients have associated pulmonary emboli. And as have been described with COVID-associated strokes, all the patients had either incomplete recovery or death, and a poor outcome have been described in these patients. Then the last group of common patients I saw was GBS. All these patients received IVIG, and at the time of discharge, 5 of the 7 patients were able to walk independently. 1 was bedridden and 1 continued to be followed up. So just to comment on what's been described with regards to brain imaging, as mentioned, ischemic strokes are common, and one study also described leptomeningeal enhancement in 60%. One specific study by Kremer et al. Looked at the abnormal patterns seen in patients who had a clinical indication for an MRI, but did not have a normal MRI, and ischemic strokes were excluded. And what emerged was 3 main patterns, and patients had either 1 or more than 1 of these patterns, the majority of patients, and these included signal abnormalities in the medial temporal lobe in almost half, multifocal white matter hyperintensities with variable enhancement and associated hemorrhagic lesions in almost a third, and then the third pattern was extensive and isolated white matter microhemorrhages in a quarter. So interesting that the majority of patients had these hemorrhagic lesions, and we don't understand fully yet why. So initially, studies have shown that CSF is actually a very good body fluid to detect SARS-CoV-2 RNA from, but only a handful of people have been reported to be positive in the CSF, and it also appears to not be a good screening tool. So a study done in France looked at retrospectively at 578 CSF samples that was collected during the peak of the epidemic in France. And of these, only 23 patients had confirmed COVID-19, but only 2 patients had a positive result. And again, we don't know why we're not seeing a higher positivity yield. I know from Di Hardy from the Division of Virology that of all specimens tested at Groote Schuur, none have been positive. So it could be that our timing of samples are incorrect, or that the method is suboptimal, and we'll have to wait for future studies looking at the antibody index, for example, to see if we can get a higher yield of positivity. And then just lastly, what has been described with regards to neuropathology, I'm just going to mention 2 studies that found diverse findings. A study from the US looked at post-mortem brain samples of 18 patients who were all confused at some stage during their illness, and they identified acute hypoxic brain injury in all of these patients. They didn't find any vasculitis or thrombi, and no olfactory bulb damage, and they performed SARS-CoV-2 PCR on 52 brain sections of these patients, and 6 were positive. However, all of them were negative by immunohistochemical analysis, which suggests that these samples were due to positive PCR from blood rather than in situ findings. And then a second study from Germany looked at the postmortem brains of 6 patients, of whom only 3 had neurological presentations. And they found that all of them had a lymphocytic panencephalitis and meningitis, with the brainstem showing perivascular and interstitial inflammatory changes, but importantly, no induced ileitis. And I think this, I just want to conclude with this, that clearly we need a lot more research on the neurological manifestations and the pathogenic mechanisms to better understand and treat these patients. Thank you very much. I will hand over to Kath, and she will start the case discussions.
Thanks very much, Suzanne. So we've got here a few brief case vignettes, which we hope will illustrate some of these manifestations. And I'll start with the first few, and then Suzanne will end with the last few and conclude. We'll be moving quite quickly. So the first case is a 62-year-old woman. She's got vascular risk factors of diabetes and hypertension, chronic kidney disease, and a history of smoking. And she presented with an acute right onset weakness in dysarthria, which was appropriately assessed as a left-sided lacuna syndrome with a moderate disability. And she had IV thrombolysis commenced at just over 3 hours. You'll see there the loss of the insular ribbon, which was an aspect score of 9. And she was found to be hypercholesterolemic and have poorly controlled diabetes. Her follow-up brain scan done the next day confirmed a left basal ganglia infarct in the deep middle cerebral artery territory. But prior to, during her admission, in fact, it came out that she had a cough for 3 days before her weakness. and it was observed that she had a mild tachypnea as well as a left lower zone infiltrate on her chest X-ray. And SARS-CoV-2 was, a nasopharyngeal swab was positive. So despite in-hospital course during which her COVID pneumonia worsened before improvement, she did well and was able to mobilize independently on discharge. And we wanted to present this case really just to make a couple of key points about stroke, and that is that despite, as Suzanne mentions, that the reports are coming out that large artery strokes in COVID do poorly, in fact, she did well. But we also want to draw attention to the fact that pre-existing stroke treatment protocols should still be followed, and that is the recommendation globally to date. Both hyperacute treatments of IV thrombolysis and mechanical thrombectomy are recommended for these patients until further data suggests otherwise. And we would advise starting standard post-acute treatment with appropriate antiplatelet treatment and prophylactic enoxaparin. I think the one situation where an individual case basis strategy of risk stratification should be employed is when deciding on therapeutic enoxaparin. As in a large infant, ideally this should be deferred by 10 to 14 days, but depends on risk stratification. So in the second case, and this is a particularly interesting case to us, this is a 36-year-old man. He had a previously healthy baseline, HIV negative, and was admitted to Groote Hospital with a confirmed COVID pneumonia. His chest X-ray shows bilateral ground glass infiltrates in his lower zones. And importantly, he was neurologically normal on admission to hospital. He was started on oxygen, prednisone, and prophylactic enoxaparin. You'll notice blood results there. Of particular interest is his sodium of 128. On day 2, however, he became profoundly agitated and disorientated despite adequate oxygen supplementation. And fairly incidentally, he was found to markedly improve in his mental state after IV diazepam. And this was assessed as a likely subclinical epileptic seizures or a COVID encephalopathy by the attending doctor. His CT brain scan was normal, but his CSF was abnormal with 8 polymorphs and 5 lymphocytes. You'll note that we've included on there the fact that the SARS-CoV-2 PCR in his CSF came back as negative. The result came back in a delayed fashion. But there are the complete results of his CSF studies. On day 3, he had persisting abnormal behavior with ongoing agitation, confusion, visual hallucinations. He had echolalia, repetitive orofacial grimacing, and limb movements. And he was clearly catatonic. But he also had a generalized tonic-clonic seizure, which was witnessed by 2 doctors in the ward. And he was managed with anti-epileptic medication, ceftriaxone and haloperidol, and his steroids were stopped. In the few days that followed, however, his EEG, seen there on the right, was performed, and this was in fact normal despite ongoing agitation and confusion, suggesting prominent catatonia at that stage. His MRI brain scan was also normal, but because of a worsening clinical condition, he was started on acyclovir and changed to olanzapine. And by day 9, he was significantly worse with marked neck, limb rigidity, and ongoing severe catatonia, although no further seizures had been witnessed. And the decision was made to commence him on IV methylprednisolone, which he was given for 5 days. And in fact, subsequent to the methylprednisolone, he made a steady and quite dramatic recovery, such that by about 10 days later, he was discharged fully recovered. This is his MRI brain, mainly to demonstrate the fact that there was no signal abnormality seen in the medial temporal lobe nor in his basal ganglia, which are regions which not infrequently show elevated signal in both viral and autoimmune encephalitides. I should note, however, that he had no microhemorrhages on his blood sequences. So this was a case of encephalitis. based on the altered mental state, seizures, catatonia, CSF pleocytosis. And as Suzanne has said, encephalopathy is far more common, but encephalitis may be diagnosed in the presence of the right suggestive features. And in him, we suggest that a rapid improvement on steroids supports an immune-mediated or inflammatory pathogenesis. But perhaps more commonly, this case might be a more common manifestation of COVID neurology. And this is a 77-year-old man with background vascular risk factors as listed: hypertension, diabetes, ischemic heart disease, TB, COPD, and a family collateral which suggested that in fact he had mild cognitive impairment which preceded his admission. He was admitted to the medical wards with confirmed COVID pneumonia requiring oxygen, and a few days into his admission developed confusion and agitation despite adequate oxygen supplementation. And his CT brain scan showed left-sided temporal encephalomalacia. No metabolic cause was found, and he wasn't found to be septic. But admittedly, he didn't have a lumbar puncture nor an EEG, and so the workup was somewhat incomplete. Nevertheless, his pneumonia improved, but his agitation persisted and took some weeks longer to settle back to baseline. And a key point that we wanted to raise from this presentation, this case presentation, is just that underlying, and it's been well described, that underlying medical comorbidities, in particular cognitive impairments, make one more susceptible to encephalopathy in hospital. And teasing out the contribution that COVID makes to these encephalopathies is challenging. It has in fact also been shown that underlying cognitive impairment may only present with a functional decline or worsened encephalopathy without any evidence of respiratory involvement in COVID infection, and so COVID should be suspected in this context. But we hope that perhaps the psychiatrist may contribute some of their thoughts on this in the discussion later. The last case that I'm going to present is a gentleman, a 52-year-old man, hypertensive on 4 agents. He presented with a day of headache and confusion, ataxia and leg weakness with a very elevated blood pressure. This was treated with IV labetalol, and the initial CT brain scan was reported as showing old lacuna infarcts, but in fact, what was overlooked was these new bifrontal hyperdensities, in keeping with an acute ischemic stroke. His chest X-ray was suspected as having a widened mediastinum, so he went on to have a CT angio of his chest, which showed features suspicious for a COVID pneumonia, which was then confirmed. And in investigating his leg weakness, he went on to have a brain and spine MRI. The spinal MRI was normal, but the brain MRI scan showed multi-territorial infarcts as seen here. These are the FLAIR images, and I don't show the DWI or ADC map, but those confirmed acute infarcts of similar ages. This demonstrates the right MCA infarction, right PCA infarction, and bilateral anterior cerebral artery infarctions as annotated. He had a normal lumbar puncture, but unfortunately he demised prior to a complete workup, and so we're left with many unanswered questions. He's a relatively young man with multi-territorial cerebral infarcts and a hypertensive crisis in the context of COVID pneumonia, with a background of untreated hypertension. But really, it's hard to tease out the relative contribution in him. And yet, again, he demonstrates the fact that patients with COVID may present with neurological symptoms and signs, including stroke, without recognition of the underlying COVID infection. Thank you.
Okay, so the next case is that of a 53-year-old man who had no known risk factors, had previous TB but completed treatment years before, and presented with severe confirmed COVID-19 pneumonia requiring high flow nasal oxygen. He was HIV negative, he had no atrial fibrillation, and his D-dimer was slightly raised. He was treated with therapeutic enoxaparin, but on day 4 of admission, he developed severely painful distal lower limbs. I was consulted telephonically about this patient, and I didn't see the patient myself, but he was reported to have cold and pulseless legs. The power was 0 out of 5 distally, and he had decreased light touch up to mid-thigh on the right and the knee on the left, with no sphincter involvement reported. So he was worked up for his acute limb possible ischemia. And here you can see the abdominal CT with contrast, which shows a infrarenal aorta thrombus, saddle thrombus with involvement also of the iliac arteries. And you can see the specks of calcification in the walls. And our presumed conclusion of what was the cause of the weakness was that he had embolized one of his reticular arteries, causing acute spinal ischemia. Now, the vascular surgeons were consulted, but unfortunately, they thought he was unfit for surgery, and he demised the next day. So this case just highlights the fact that the severe thrombotic associations that we can get with COVID, in spite of treating patients with therapeutic enoxaparin. The next patient is a 79-year-old man who was independent for all activities of daily living. He had a history of bowel cancer a few years before, but this was completely resected, and he presented as well with severe confirmed COVID pneumonia, requiring double oxygen. He was also treated with prednisone and therapeutic enoxaparin. But on day 4 of admission, he had features of an acute stroke, and he was seen by my colleagues Sterren Europa and Professor Janine Heckman. So the history was that he had severe headaches and vomiting, dysphagia, and a right hemiparesis and hemisensory disturbance. And he was noted to have a small laceration above his left eyebrow. And he admitted to having a fall 3 days prior to admission. So the concern was that he might have had a bleed, and an urgent CT brain was done, which confirmed a large subdural with mass effect and at midline shift. Now, he unfortunately deteriorated quite rapidly and died within hours of the symptom onset. And we're showing this case just to emphasize that there can be serious complications with therapeutic enoxaparin, and judgment should be used in the elderly when to start this. Then the last case that I'm presenting is a 69-year-old female with a background of hypertension and dyslipidemia. She had a good baseline and was admitted to Frederiksberg with confirmed COVID pneumonia requiring oxygen. She was also noted to having increased BMI, and she was newly diagnosed diabetic. She did well from a respiratory point of view and was transferred to a step-down facility after 2 weeks, where they treated her with 5 days of steroids. The steroid trial just came out at that stage. However, she was readmitted 1 week later after 2 days history of the following symptoms: increased shortness of breath and oxygen requirements, paresthesias of the hands and feet, and difficulty standing and holding objects. So, on examination, she was dyspneic. She had SATs of 96% on non-rebreather, which was much, she required much more oxygen than before. And positive findings were that she had mild neck flexion weakness, she was areflexic and quadriparetic, and this was distal more than proximal, and she had a stocking glass sensory disturbance. A chest X-ray actually showed improvement from what he did on the previous admission, and the CSF showed a slightly raised protein and IgG index without any cells. And because she was unwell and because we made a clinical diagnosis, we did not perform nerve conduction studies at that stage. She had the diagnosis of Guillain-Barré, and we managed her with IVIG and therapeutic enoxaparin. Unfortunately, she deteriorated respiratory-wise, and she required intubation, and subsequently developed sepsis, and she demised 10 days after a second admission. And here it's just showing the complexity of managing patients who's got GBS, who also have COVID pneumonia, because you've got two potential causes for respiratory distress, and it's often difficult to tease out which is the major contribution. And the second point is that IVIG can also cause thrombotic complications, and in other words, it worsens the potential coagulopathy of COVID-19, and it's uncertain if we should be using therapeutic enoxaparin in all these patients. And with this, I thank you, and we will take questions.
Thanks very much, Suzanne and Kathleen. That was a fantastic overview. Covered a lot of ground, and really gave us a feel of the spectrum of neurological complications in this condition. And just to say thank you to the two of you also for all the work that you've been doing in the COVID wards over the last few months, looking after all patients with COVID, and particularly your specialist input on patients with the neurological complications. So at this point, I'm going to bring in our panel members. As I said earlier, two colleagues from the Department of Psychiatry, John Joska, who's head of the Division of Neuropsychiatry at Groote and UCT, and Jackie Hall, who is the head of Division of Consultation Liaison Psychiatry, also at Groote and UCT. And I'm particularly, wanted to emphasize that, and as Suzanne and Kathleen have emphasized, is that in addition to the neurological complications, there are also a range of neuropsychiatric complications, and we're interested to hear from John and Jackie their experiences and their thoughts on those neuropsychiatric complications, and some insights into how they think those are best managed. So to bring in John at this stage, I think John is on the webinar and hopefully unmuted. John, just interested in your experiences and thoughts and insights.
Yeah, thank you very much, Graham. Maybe what I need to do in order to make some comments is just to step back a little bit and point out that if we look at the whole population of people who are non-infected with COVID, they're impacted by the anxiety of the epidemic, the socioeconomic issues, and the care of their loved ones and living in these communities. We have a group of people who are COVID infected who are not admitted to hospital, and we have very little information about the impact of COVID on those people. Then we have a group of people known as healthcare workers, and so we need to consider the implications of COVID on them. And then what we've been talking about are these COVID infected individuals who've been admitted to hospital, so with mild to moderate disease. And those people we can divide from a psychiatric point of view anyway into those acutely admitted and those who are post-acute and recovered and at home. So Jackie's got a lot of experience hands-on with the acutely admitted patients, but we do know that a range of neuropsychiatric syndromes and symptoms can present in these patients, anxiety, depression, cognitive symptoms, mood lability, confusional states, etc. The long-term outcome data we don't have a lot of clarity on. We have to rely on other coronavirus epidemic outcomes. So from SARS and MERS, it seems that post-traumatic stress disorder might occur at quite high rates, up to 30% over 2 to 3 years. And then, of course, cognitive syndromes and symptoms may also persist. The extent to which people develop cognitive symptoms may be partly due to the severity and extent of neuro-COVID that they've endured in hospital, and possibly due to unrelated premorbid and comorbid factors. The only other thing to say is that COVID is a very strange disease. It's a once in a century thing. It's resulted in a lot of emotional and physical isolation. Patients lie very alone and in hospital, they're often prone if they're being ventilated. They encounter doctors behind clothing and barriers and masks. They're separated from their families. And I think it's very important to understand that that has a profound impact on the development of post-traumatic stress. But let me hand over to Jackie and see if she has anything to add.
John, just before bringing Jackie in, if I could just ask you to just briefly give us a sense of what the impact of COVID has been on patients with chronic psychiatric disorders, both in an inpatient setting like at Falkenberg and your outpatients, and the impact that this epidemic has had on those and on that population group.
Right. So I suppose I could make a couple of random remarks because we haven't studied it systematically. But first of all, community-based services have largely de-escalated, as have all the other services. So our outpatient clinics are very poorly attended. So we're not sure what kind of care those people are getting, those people who need chronic care. So that factor, plus the additional anxiety and isolation of living in lockdown, is probably having a significant effect on these people. Secondly, we've had to reconfigure our inpatient services to try and cater for medical COVID, as well as those patients with severe mental illness who come into our service. My reading of the literature and my experience at British Care is that COVID is actually not a driver of psychosis in a direct fashion. So we've not seen big surges of numbers of psychotic individuals. There have been people with pre-existing conditions or substance abusers who've been part of an outbreak, a ward outbreak, as it were. So once or twice we've had these big bubbles of people infected, but in general, it's not a driver of psychosis. And the long-term impact remains to be seen. It's something that we have to keep a very close eye on and do our best to try and mitigate the effects of.
Great. Thanks very much, John, for those insights. So, Jackie, from your perspective, having also worked in the COVID wards and your experience of the neuropsychiatric manifestations.
Yeah, thanks, Graham. I'd first of all just like to say thank you to Kathy, who assisted us with a gentleman who presented with catatonia. He was actually referred to psychiatry initially. And I just want to say thanks to Kathy for trusting me that I didn't think this was a primary psychiatric illness and that I felt that it was a neurological condition. Kathy has helped me with a number of cases over the years with quite unusual neuropsychiatric presentations. So thanks, Kathy. And I would agree with John's comment about psychosis. I certainly haven't seen a lot of psychosis, and when I mean what I'm talking about, I suppose, is psychosis caused by COVID. We have seen some psychoses caused by steroids. Steroid psychoses have been a common phenomenon in our service for years, actually. And of course, higher dose steroids are sort of more likely to cause psychoses. These respond pretty well, though, to reducing the dose of steroids and of course, the addition of a very low dose of antipsychotic. So the COVID psychoses I've seen, my suspicion is that most of those have actually been driven by steroids, because they have responded to the reduction in dose of steroids. And of course, there's also the psychotic symptoms that occur in the context of delirium, but I don't call that psychosis. I mean, those are, that's part of the sort of syndrome of delirium. But of course, hallucinations are a common phenomenon in patients who are delirious. And in the webinar that we did 2 weeks ago, we kind of discussed the management of delirium, both delirium where we're treating the delirium, where we're expecting reasonable outcome and in the management of terminal delirium. And I'd just like to encourage everybody to go back and have a look at that webinar. But of course, more commonly are the sort of, mental health distress symptoms in patients, which may or may not be neuropsychiatric, because they're actually really quite understandable. I would imagine I'd feel very similarly to some of the patients in terms of the sort of fear and anxiety around having COVID.
Great. Yeah. Thanks very much for those comments, Jackie. And yeah, as you emphasized, the issue of the management of delirium, particularly in elderly patients with COVID, we did deal with in the webinar 2 weeks ago, and the issues around low dose antipsychotics in those patients, and that people are interested can go back to that webinar. If I could just pose one question to both Suzanne and Kathleen about the strokes that have been reported in patients with COVID. Are there unusual features of those in terms of the age distribution or the territories that are affected, or any other features that are clinically described in the literature?
Thanks, Graham. I'll take us down first. Just to say that, firstly, the literature has reported increased number of large vessel strokes at younger ages than would be expected in patients with a lack of traditional vascular risk factors. So that, in a nutshell, would be the kind of strokes that are presenting in association with COVID. But particular vascular territories have not, to my knowledge, been reported. There have been some reports of multi-vessel territories, like the patient we presented. Of course, there were other factors in him which could come into play. But large vessel strokes, more multi-vessel territories, and younger age group with less vascular risk factors is the main group that are being described in these COVID-associated strokes. Suzanne, do you have any further comment? No.
Okay, great. So, Mark, perhaps you want to take questions from the floor if they've been posted in the chat room.
So there are 2 questions so far. How do you distinguish steroid or critical care polyneuropathy from Guillain-Barré syndrome? The patient following extubation, and importantly has severe weakness and you're unable to do an LP due to being morbidly obese, technical difficulties in doing an LP.
Yeah, so I think nerve conduction studies will be quite important in such a patient, because you don't know when the onset was, so you don't have a clinical history to go on, and then also other features of GBS with neck flexion weakness, bulbar weakness, and things that you don't generally see in a critical care neuropathy. Okay?
Yeah, I would agree. I think critical care polyneuropathy tends to occur in the right clinical context, firstly. So you would expect such a patient to have a prolonged ICU admission. There may have been the use of beta-2 agonists and steroids. It would be a difficult thing to tease out. However, the context is helpful. And then, as Suzanne pointed out, nerve conduction studies can be valuable, as well as the cyto-alveological dissociation that you express interest in looking for. But it can be challenging. I think particularly the right context is helpful. Yeah. We would expect an axonal polyneuropathy in the critical care polyneuropathy. We wouldn't expect to see demyelinating features. And we wouldn't expect to see that protein cell dissociation.
And so there's another clinical question here. 31-year-old female, otherwise healthy, severe headaches, and only started prednisone 20 milligrams daily on day 10 after testing positive. In the opinion of the neurologist, do I need other tests at this stage, and how long do these headaches last, more or less?
Well, I think any new onset severe headache in the right context needs to have further investigation. So I would suggest the patient does need further investigations to exclude other causes. You can't just assume the causality in this patient. So I would go ahead and do a CT and a lumbar puncture to rule out additional causes.
Yeah, on that note, I would also just add, though, that headaches are quite commonly seen in viral infections. So whilst it is important to investigate when they're severe and new, often a gradual onset of headaches and quite persisting headaches are not uncommon for viral infections.
This is a question maybe to bring in our panelists. With many post-COVID-19 patients presenting with post-viral fatigue syndrome, how easy is it to tease this out from major depression? So distinguishing post-fatigue.
I would say firstly, you need to explore mood symptoms. So depression and anhedonia would need to be core features of that syndrome in order to diagnose major depression. Secondly, you may want to wait a week or two if you can, if it's clinically possible, to see if there's a trajectory of recovery in a post-viral condition. And thirdly, if you're not sure and mood symptoms are present, you might then be forced to treat with antidepressant treatment, and you would expect to see a response within 2 to 4 weeks.
Jackie, anything from your side?
Yeah, thanks, John. And I support everything that John has said. I mean, the key thing is really to have a conversation with your patient and ask about their subjective, sort of mood experience. Interestingly, I've been contacted by a number of patients who are describing something that looks like chronic fatigue syndrome, particularly patients who have got COVID quite early in the pandemic. Some of these patients got COVID as early as March and are still struggling with quite profound fatigue, such that they are describing that sort of syndrome that we sort of classically would describe as chronic fatigue syndrome, which I view as something quite distinct from fatigue. They're describing very minimal exercise, resulting in them having to take themselves to bed for an extended period of time. So there certainly seem to be some case reports as well from the international literature that this might be a phenomenon. It was described in the Spanish flu pandemic, and the hypothesis there was that it may have been related to the virus there targeting some dopaminergic neurons. So I think importantly, when we follow patients up long term, is to not only kind of focus on the sort of respiratory fallout that these patients may experience post-COVID, but also to keep an eye out for long-term neuropsychiatric, neurological, and psychiatric symptoms. And I think including it in that would be a screen for fatigue.
A few more clinical questions here. Is there any link between the first onset seizure post-COVID infection? Appears to be 5 weeks post-COVID. Can we still relate this to COVID?
Seizures have been associated with this COVID infection, although it's case reports, but obviously if you've got a parainfectious phenomena, you might present with seizures, so it is possible that it could be linked, yes. And such a patient does need imaging.
And then this seems quite a difficult question. Have you seen cases of ulcoclonus myoclonus syndrome as a parainfectious complication?
There have been cases reported. I think that's obviously a specific parainfectious syndrome, which would be grouped with in the autoimmune encephalitis grouping. And to speak to that, we should say that there are case reports coming out on a weekly basis of immune-mediated encephalitic complications associated with COVID. There have been NMDA receptor antibody encephalitides. There have been so Casper-2 antibody encephalitis. These are autoimmune forms of autoimmune encephalitis, and obsoclonus myoclonus syndrome can be the clinical presentation of an autoimmune encephalitis. So yes, it has been described, and there's quite a wide spectrum of autoimmune encephalitis that is being reported, but in a stuttering fashion. We have sent off, for your interest, antibodies for our particular case to see if this is a COVID-triggered, recognized antibody immune-mediated encephalitis, but those are not out yet.
And then what's very commonly asked, is anosmia linked to other CNS involvement? Thought that it might be indicative of milder infection and a less complicated clinical course, or is there any relationship at all?
So it's uncertain what the cause of anosmia was, and that's why I mentioned that in the one study they found no abnormalities of the olfactory bulb. So it's uncertain if it's an epithelial phenomena, although these patients often don't have runny noses. Is it a peripheral nerve, or is it a receptor problem, or is it an olfactory problem? I don't know that it's been linked to other CNS symptoms particularly, but what we do see quite commonly, and I don't know if Kathy, if you also noticed it, that patients who come into casualty with respiratory problems report that they have had anosmia and it has recovered. But also interestingly, so if you recall the first slide, anosmia was in that in hospital patients was in 5%. Now this was much lower than an outpatient study which reported more than 80% of patients having anosmia. So, which might suggest the larger population having more often. However, the study with the more than 80% prevalence for anosmia, at that stage it was known that there was a link. So it could have been that people would just ask more systematically if they had anosmia rather than relying on self-report.
Yes, I think in direct response to that question, I don't think it's clear that it is linked to a less complicated clinical course at this stage.
And then probably one of our last questions, I think, is COVID giving us any different CSF picture from the regular viral CSF picture, and how different is it?
Well, I think the main point we wanted to make was the fact that encephalopathy in COVID is usually associated with the normal CSF in the majority of cases. And so finding cells in the CSF is atypical for starters for a COVID encephalopathy. But the numbers of cells in the CSF are low in the cases that I've seen reported, less than 100 certainly, less than 20 in quite a number of cases, and then predominantly lymphocytes. So that would be typical of a viral encephalitis or even meningitis.
And then maybe just one last comment. In terms of comorbid risk factors, age, obesity, diabetes, do they play a role at all in making you more likely to have CNS presentations?
Well, it has been reported that if you have more comorbidities, then you are more likely to have neurological manifestations.
Graham, I think we've covered most of the questions.
Okay, great. So just to say thanks to all of the speakers today for a fantastic session, Marianne, Suzanne, Kathleen, and then John and Jackie, our panelists. And to say that next week we will be hearing from Ross Hoffmeyer. Ross from the Department of Anesthesia has led our intubation team at Groote and will be discussing his experiences and some of the approaches to intubation in patients with COVID-19. And then to also say that if people are interested in watching some of the previous webinars that you missed, that all the recorded webinars are available on the Department of Medicine, UCT Department of Medicine website. And perhaps we'll put up the link to that next week, but you can search for it online. So thanks very much to everybody, and we'll see you again next week.
Thank you very much, and thank you to everyone. As Graham said, we'll see you next week again. Thank you to all for participating. Again, thank you to Karen Fenton and Cheryl Valentine at the back end from the Gastro Foundation and Project ECHO for assisting us. And I just wanted to say, again, A shout out to Professor Saunders, who is a stalwart at the webinars every week. Prof, we hope you're keeping safe. And for those of you who don't know, Professor Saunders, ex-Vice Chancellor of the University of Cape Town. Hope you're well, Prof. Thank you, everyone.